टिकट मिलेगी। लो भैया।
Okay.
Dr. Prerna, I'm waiting for the other participants to join in 5 minutes and then we'll start. I
All
think
right,
there is
all
some,
right.
yeah. Hello, Dr. Prerna, am I audible?
Yes, yes.
Dr. Prerna, we have around 10 students who registered as a paid, registrant, and there are 20 who filled the form. So we are expecting that 30 people who would join because we have given the access. But yet the paid one and the faculties, from which colleges we allowed them to, join without paying and without registration. So we are expecting some, say, 20, 30, participant who would be joining, but there is some issue. I don't think the people are not able to log in, or there are, people who are, those who haven't paid actually. So they are not taking it actually. So they are not, entered into the Zoom. So what I would recommend you, we have made it live on YouTube. So it would be in our records, and it would be used later on as a recorded video. So we have only one participant, Mr. Prashant Bhatnagar. And there are 2, 3 girls who are, who is in MBBS first year in colleges in UP West. So they would be joining in a couple of minutes. So it is up to you. Should we start now? And it would be the people as when they would be getting, there might be some technical issue as well. So my IT team is handling that. By the time we'll start, and it is being recorded on YouTube, so we'll use at a future, study material and all. So it's up to you how, we should go about it.
We can start, but I think the lecture is lengthy, so I can't finish till 1 p.m.
No, let's start, and we'll make, the other lecture a bit delayed actually. You have all the time, not to worry.
All right, all right.
Mhm.
So
I have made you co-host, and you can share your slide. And it is live on YouTube as well, our National Health Academy channel. So we'll use it. I'll share you the link, and the other students as well. They will see it, and they will get the benefit out of it. Those who are joining live here, they're most welcome. So you can start. It is going on the records actually.
all right, all right. So everyone, good morning. So I have done my MBBS from Maharani Lakshmibai Medical College, Jhansi, and then my post graduation from SM Medical College, Agra. And after my post graduation, I have joined FH Medical College in Agra for 1 year, and after that in Bharatpur Government Medical College for further 1.5 years. Then I have joined as assistant professor in medical college, Government Medical College, Shahjahanpur for around 2.5 years. And now I am presently working in AIMS Gorakhpur as assistant professor. So today we will discuss about the female reproductive tract anatomy. So we will starting now. Okay. So yes. Okay. Right.
Yes.
So I think I am visible and audible both. Okay.
Yes. You're visible and audible.
All right.
Yes.
Okay. So the internal genitalia of female consist of vagina, uterus, paired uterine tubes, and paired ovaries. So as you all know, the function of ovaries to produce eggs and also sex hormones. The oviducts are the normal site for fertilization, and they carry ova into the uterine cavity. The uterus is the normal site for implantation, and also the development of fetus takes place further in the uterine cavity. Cervix is the opening to the uterus that can dilate during childbirth. Vagina is the birth canal. So let's talk about the uterine tube in more detail, which is also known as the fallopian tube. So here, these are the uterine tubes, right and left. They are tortuous ducts, and they convey ova from the ovary, which is this, to the uterus, and sperm from the uterus to the tube. So that fertilization takes place in the uterine tube itself. These uterine tubes are situated in the upper free margin of the broad ligament. So this part, which is actually the peritoneal folds, both the sides of uterus are the broad ligaments, and the fallopian tubes are running on both the sides on the upper margin of the broad ligament. These ducts are the 10 centimeters in length. So these uterine tubes are in communication medially with the uterine cavity and laterally opens into the peritoneal cavity by abdominal ostium. Okay, so as you all know, this uterus and the fallopian tube are actually the pelvic organ. All right, so there is communication of uterine tube by means of abdominal ostium to the peritoneal cavity. So this is the pleural cavity, and the part above this, this is the perineal cavity, and the part above this perineal cavity is the abdominal cavity. So there are at the lateral end of uterine tube, there are fimbriae which sweep oocyte into the tube, and further the ova transported into the tube by means of cilia which are present in the uterine tube and the peristalsis of the uterine tube. The fertilization occurs within the tube and within 24 hours after ovulation. So what is the course of this uterine tube? Actually, uterine tubes are tortuous structure, and so the pelvic size of pelvic cavity is not very roomy. So the length of this 10 centimeter long tube is accommodated due to this tortuous course of uterine tube. So this tube at first passed laterally from the angle of uterus up to the uterine end of the ovary. So this is the uterine end of the ovary, and the tube passes laterally, then upward along the mesovarian border. So ovary has this mesovarian border along which this uterine tube running and arches backwards around the tubal end of the ovary. Finally, this tube turns downwards and comes in contact with the posterior border and the medial surface of the ovary. Okay, so this course is very important. Tube runs first laterally, then upwards, then backwards, and finally downwards. So what are the relations of uterine tubes? In this broad ligament of uterus, there are two main structures are running. One is uterine artery and other one is the ureter. So this uterine tube is related below with the anastomosis of the ovarian artery and uterine vessels. Ovarian artery are also running from above, and uterine arteries are running from below. This uterine tube is also related below and in front by the round ligament of uterus, and below and behind ligament of ovary. So the picture which you are seeing is the posterior aspect of the uterus. This is the ovary which is attached to the broad ligament, the posterior layer of broad ligament. So you are seeing the uterus posteriorly. Okay. So what are the parts of uterine tube? There are four main parts. One is the intramural part or interstitial part. Mura means the wall. So this part lies within the wall of the uterus, and it is around 1.25 centimeters. Next part is the isthmus, which is straight and narrowest part, and it is around 2.5 centimeters. Third part is the ampulla, which is tortuous and widest part, and it is the site of fertilization. Remember, ampullary part of the uterine tube is the site of fertilization, and it is around 5 centimeters. Fourth one is the infundibular or infundibulum, which is around 1.25 centimeter long, and there is an abdominal ostium present here. which is surrounded by the fimbriae, and one fimbriae is lengthened or long as compared to other fimbriae, and this is known as the ovarian fimbriae. So there are 4 parts: intramural part or interstitial part, isthmus, ampulla, and the infundibule. So what is the arterial supply and venous supply of uterine tube? Because uterine tube is in relation to the ovarian artery and the uterine artery. So it is supplied by both these arteries only. Medial 2/3 part of this uterine tube is supplied by the uterine artery. This is the uterine artery, okay? And later 1/3 part is supplied by the ovarian artery. This is the ovarian artery. And the veins correspond with the arteries only. So uterine vein and ovarian vein going to drain. What is the lymphatic drainage? So most of the lymphatic drain into the para-aortic and pre-aortic lymph nodes. These are the uterine tubes, and the lymph is going to drain into the pre-aortic, which is anterior to the aorta, and para-aortic lymph nodes are situated parallel to the aorta. So lymphatics from the intramural part or interstitial part of the tube drain into the superficial lymph node. So all the lymphatic drainage going into the pre and para-aortic lymph node, except the intramural part or interstitial part of fallopian tube, which is drained into the superficial inguinal lymph node. Nerve supplies, sympathetic nerves and parasympathetic nerves are supplying the uterine tube. Sympathetic nerves come from the T10 and L2 segments of spinal cord, and they form the ovarian and superior hypogastric plexus. So ovarian plexus and superior hypogastric plexus. These plexus is vasomotor, and the peristalsis is controlled by the hormones. It is stimulated by the estrogen hormone, and peristalsis are inhibited by the progesterone hormone. Parasympathetic nerve supply is through the vagus, which supplies the lateral half of the tube, and through the pelvic splanchnic nerve S2, S3, S4 segment of spinal cord supplies the middle half of the uterine tube. So uterine tube, lateral half and middle half parasympathetic supply is different. Medial half is supplied by the pelvic splanchnic nerve, which are nerve fibers which are coming from S2, S3, S4 segments of spinal cord, and lateral half of the tube is supplied by the vagus nerve. And they inhibit peristalsis. The parasympathetic supply inhibits peristalsis and causes vasodilatation. So applied aspect related to the uterine tubes are one is the tubal ligation, which is a simple and effective method for the birth control. The tubes are cut, both the ends of the tubes are cut and ligated by means of the surgical thread, or by clips, or by staples, so that the fertilization is prevented, and also entry of this fertilized embryo is prevented going to the uterine cavity. One term which is related to the ectopic pregnancy is the pregnancy which normally pregnancy occurs in the uterine cavity. The implantation of fertilized ovum is occurred in the uterine cavity, but sometimes when it occurs outside the uterine cavity, either it is in cornual part or the isthmic part or ampullary part, cervical part, or even in the peritoneal part, peritoneum of uterus, and also the abdominal cavity. So any site other than the uterine cavity, if fertilization or an implantation occurs here, then the pregnancy which results is the ectopic pregnancy, and it is not normal, and it is actually the emergency condition. It may be it may rupture and cause shock to the patient. Sometimes this uterine tube may get infected and inflamed. This condition is known as the acute salpingitis. Acute salpingitis. Salpingitis word is related to fallopian tube only, and this condition is comprises of the, or it is the part of the pelvic inflammatory disease, PID, pelvic inflammatory disease. So acute salpingitis is the inflammation of the uterine tube. So hysterosalpingography is the radiological study of the uterine cavity, and the most common indication for hysterosalpingography or salpingograph is the infertility. So we inject the dye through the cervix into the uterine cavity, and then we take X-ray picture and we see the spillage of this dye into the abdominal cavity. If there is spillage in the abdominal cavity, that means the uterine tubes are patent. Uterine tubes are patent. But if there is no spillage into the abdominal cavity, means that the uterine, then these fallopian tubes are non-patent, they are blocked. That's why resulting into the infertility. Then later on, we explore the cause of infertility, and according to the cause, we manage the patient. So this is the hysterosalpingography. This is the uterine cavity, and these are the fallopian tube. See the spill of dye, which means both the tubes are the patent or unblocked. Next topic is the ovaries. So ovaries are the female gonads or sex glands. They develop and expel an ovum each month. And the female is born with approximately 400,000 immature eggs at the time of birth. And at the time of puberty, there are only 40,000 of these immature eggs are persist. During lifetime, a female releases around 400 to 500 fully matured eggs for fertilization. And the follicles in the ovaries, which are present in the ovaries, they secrete or they produce progesterone and estrogen, which are the female sex hormones. These hormones prepare the uterus for implantation of the fertilized egg. So ovaries are the almond shape structure, which is around 3 centimeter long, 1.5 centimeter broad, and 1 centimeter thick. It is around 4 to 8 grams in weight, and it is present in the ovarian fossa, which is our peritoneal recess. Ovarian fossa, depression of peritoneal recess.
Dr. Prerna, I'm just interrupting you. I think slide is not moving actually. We are still stuck on the slide number 3, I think. So please look at once.
Yeah.
Anatomy of female reproductive organs. The first slide, the title slide is visible to us. I think it's slide number 3. Yes, no, it's visible. Okay. Go ahead. Thank you.
So ovaries are almond in shape, 3 centimeter long, 1.5 centimeter broad, and 1 centimeter thick, weighing around 4 to 8 grams. And they are located in the ovarian fossa, which is attached to the posterior layer of broad ligament, below and behind the ampullary part of the uterine tube. Because I already told you that these ovaries are attached to the posterior aspect of the broad ligament. And this ovarian fossa is the recess of peritoneum only. So both the ovaries are located in the ovarian fossa. So this structure is the ovarian fossa, and this is the uterine tube. So what are the boundaries of this ovarian fossa or peritoneal recess? So this ovarian fossa is the peritoneal recess, which is present between the mesosalpinx, which is again the peritoneum only, peritoneal fold, and the medial surface of the ovary. So this is the mesosalpinx part. So this ovarian fossa, which is the peritoneal recess, it is anteriorly bounded by the obliterated umbilical artery. This green structure is the obliterated umbilical artery and the external iliac artery. Posteriorly by the ureter and the internal iliac artery. And inferiorly, it is bounded by the uterine tube. Inferiorly by the ureter, and the floor has obturator nerve and the obturator vessels. So ovarian fossa, again, anteriorly it is bounded by the obliterated umbilical artery and the external iliac artery, posteriorly by the ureter and the internal iliac artery. Inferiorly, it is bounded by the this uterine tubes, and in the floor of this ovarian fossa, ovarian nerve, obturator nerve and obturator vessels are present. So this is the uterine tube, which is related to ovarian fossa inferiorly, and in the floor there is obturator nerve and also obturator vessel, obturator artery and obturator vein. So any exploration in this region can cause damage to the obturator nerve and the ureters, which are related posterior. So ovaries before puberty, they are smooth and grayish pink in color. After puberty, they are rough and gray. The pinkish stain is gone. Okay. So in ovaries, there are two poles, upper pole and lower pole, and two borders, medial and lateral border, and also two surfaces, anterior and posterior border, and two surfaces, medial and lateral surface. So what are the relations of presenting part of ovary? So this is the upper pole. This is the upper pole, which is also known as the tubal pole because it is related to uterine tube, fallopian tube, and the external iliac vein, ovarian fimbria, and suspensory ligament of ovary. So upper pole is also known as the tubal pole. So what are the structures which are related to this tubal pole or upper pole? One is the fimbria of the fallopian tube and the external iliac vein, and the suspensory ligament. The lower pole or uterine pole, it is related to the uterus. That's why it is called as the uterine pole. So this pole is related to pelvic floor and it is connected to the lateral angle of the uterus by ligament of ovary. So two borders, one is the anterior border or the mesovarian border. So this, in this picture, you are seeing the uterus anteriorly. This is the urinary bladder, this is the uterus, this is the rectum. So anteriorly, this ovary has anterior border or mesovarian border. So this mesovarian border is straight and it is related to fallopian tube. It is attached to the back of the broad ligament by mesovarium, which I already told. So this anterior border is attached to the posterior layer of broad ligament by the mesovarium, and it forms the hilus of the ovary. This border is the posterior border, which is free border, and it is related to the fallopian tube and the ureter. This is the ureter. So posterior border or free border is related to the fallopian tube and the ureter. Two surfaces are there, medial surface and lateral surface. So this surface is the medial surface, which is covered by the fallopian tube. And the lateral surface is related to the ovarian fossa and the obturator vessels and nerves. So two poles, two surfaces and two borders are present in the ovary. So what are the peritoneal relations? This peritoneum covers the ovary entirely, except at its anterior border or mesovarian border, where two layers are reflected as mesovarium on the posterior surface of broad ligament. So the fold of peritoneum is mesovarium, which is attaching the ovary to the posterior layer of broad ligament. And here, along this border, there is no peritoneum. No peritoneum here. So the mesovarium, as you know, this is a short fold of peritoneum. The peritoneal layers of mesovarium become continuous with the germinal epithelium of the ovary. So this germinal epithelium of the ovary is which type of epithelium? It is cuboidal type of epithelium, while the mesovarium, which is fold of peritoneum only, it consists of the squamous type of epithelium or flattened epithelium. So the line of fusion or line of attachment between peritoneum and the germinal epithelium is marked by white line of ovary, which is also known as a line of fusion. So the junction between this flattened mesothelium of peritoneum and the cuboidal germinal epithelium of ovary. This mesovarium transmit ovarian vessels and nerves to and from the ovary. Okay, so this is a fold of peritoneum only, which transmits the ovarian vessels and nerves. What are the ligaments of ovary? One ligament is the suspensory ligament of the ovary, or also known as the infundibulopelvic ligament. So this ligament is the suspensory ligament or infundibulopelvic ligament. It extends from the tubal end of the ovary to the pelvic wall. So this infundibular part of the fallopian tube is attached to the lateral pelvic wall by means of this fold, suspensory ligament or infundibulopelvic ligament of ovary. The structures which traversing through this suspensory ligament are the ovarian vessels, nerves, and lymphatics to the broad ligament. Other one is the ligament of ovary. It is a fibromuscular fold, cord-like structure, which extends from the uterine end of the ovary to the lateral angle of the uterus. So one ligament is the suspensory ligament of ovary, through which ovarian vessels and nerves, lymphatics are passing. Other ligament is the ligament of ovary, which actually holds the ovary to the suspend the ovary to the uterus. Third fold is the mesovarium, which we have already talked about. It is a peritoneal fold which extends from the upper layer of the broad ligament to the anterior border of the ovary, and it transmits the ovarian vessels. These are the ovarian vessels which are coming through the suspensory ligament and going to this mesovarium. Ovarian vessels and nerve to the ovary. Ovaries are supplied by the ovarian artery here, and this ovarian artery comes from the abdominal aorta. So right and left ovarian artery are the direct branches of the abdominal aorta. Venous drainage is through the pampiniform plexus. So this pampiniform plexus firstly form the ovarian vein, right ovarian vein and left ovarian vein. This right ovarian vein drains into the inferior vena cava directly, while the left ovarian vein first drains into the left renal vein and finally into the inferior vena cava. So this difference is very important, very important. So what are the lymphatics of the ovary? Para-aortic lymph nodes. Para-aortic lymph nodes and pre-aortic lymph nodes are drain lymph from the ovary. So here, para and pre-aortic lymph nodes are related to the abdominal aorta, and the lymphatic drainage from the ovary is going to these nodes. So the nerve supply the sympathetic and parasympathetic nerves are going to form the ovarian plexus. Sympathetic nerves are coming from the T10, T11 segments of the spinal cord, and they are vasomotor and carry pain sensation. Parasympathetic nerves are from the S2, S3, S4 segments, also known as the pelvic splanchnic nerves, and they are the vasodilator. So clinical anatomy. One term is the polycystic ovarian disease, which is very common, and in this there is hormonal disorder. There is imbalance between estrogen and androgen hormones, which leads to enlarged ovaries with multiple small cysts, and the exact cause is not known for polycystic ovarian disease. Some say it is genetic and some says it is environmental factor. There are many environmental factors which are related to polycystic ovarian disease. But this is quite annoying disease, and there is abdominal pain, lower back pain, urination problem, patient is obese, weight gain, menstrual disorders are there, abnormal bleeding, menstrual pain is there, nausea and vomiting. So these are the symptoms of polycystic ovarian disease. So ovarian cysts are many types. One is endometrial cyst, other one is chocolate cyst. So these cysts you are study in detail in final year gynecology department. Other term is the dermoid cyst, which is the abnormal development of 3 germ layers while development of embryo. So there is cyst in the ovary which consists of hair, which has teeth. So this is the dermoid cyst. Sometimes this cyst twist, and resulting is the twisted ovarian cyst. And again, this condition is the emergency condition. A patient can go into the shock. So ovarian cancer is also quite common cancer, and in this we have to remove the ovaries. So removal of ovary is known as the oophorectomy. Either it is unilateral or bilateral. And if we remove fallopian tube along with the ovaries, then it is known as the salpingo oophorectomy. Salpingo is uterine tube, and oophorectomy is the removal of ovary. So next, viscera is the uterus. So uterus is the hollow, pear-shaped organ, very muscular organ, which is situated in the lesser pelvis between the urinary bladder. So this is the urinary bladder anteriorly, and posteriorly there is rectum. So between the urinary bladder and the rectum, uterus is situated, and it is hollow and muscular organ. Dimensions are, it is around 7.5 centimeter in length, 5 centimeter in width, and 2.5 centimeter is thickness. Weight is around 30 to 40 grams. So functions, it receives the fertilized ovum, provide appropriate environment for developing fetus, and it is before the pregnancy, it is around pear shape and size. So size is very small, but after but during pregnancy it enlarges enormously, and it becomes the abdominal organ instead of pelvic organ. So during pregnancy, it is no longer remains the pelvic organ, it becomes abdominal organ. And after childbirth, uterus regresses. And also after menopause, this size again becomes small and it regresses. This is the picture of external features of uterus, and this is the internal view of uterus. In this, part is the fundus part, body, stomach, cervix, and vagina. Here, internally, if we see, this is the uterine cavity, body, stomach, which approximately correspond to the internal os, the constriction. This is the external os, and between internal os and external os, the cavity of cervix is known as the cervical canal, and this is the cavity of vagina. So as you see in this picture, the fundus part of uterus doesn't have the uterine cavity. Okay. So what is the normal position of uterus? It is anteverted and anti-flex position. What do you understand by version? Version means relation of uterus with the vagina around a transverse axis passing through the external os of the cervix. So normal position of uterus, anteversion. What do you understand by anteversion? Anteversion is this. The long axis of cervix is bent forward over a long axis of vagina. So this red axis and this blue axis forming an angle which is known as the angle of anteversion, and it is around 90 degrees. It is around 90 degrees. It is the angle between the axis of cervix and the axis of vagina. Anteflexion, what is anteflexion? Long axis of uterine body or uterus, body of uterus, this green one, is bent forward at the level of internal os with the long axis of the cervix, this red one. Okay, so the angle which is forming between this green and red, the axis of uterine body and the axis of cervix, is known as the angle of anteflexion, and it is around 170 degrees. So this is the normal or usual position of uterus, anteversion and anteflexion. This version is maintained, anteversion is maintained by the forward pull on the fundus by the round ligament of uterus, which shortly we will talk about. Backwards by the pull on the cervix by the uterosacral ligament, and also the intrinsic growth of uterine musculature. So this pulley-like structure which is forming due to round ligament of uterus, which pulls the fundus of uterus anteriorly, and the uterosacral ligament which pulls the uterus posteriorly. So anteversion is maintained by the help of these two ligaments, round ligament and the uterosacral.
Dr. Prerna, slide is not moving. Could you please move the slide so that it will be visible? I think your lecture and your slide is not matching, I think.
Okay.
We are on slide number 23, I think. If this is a problem, you can stop sharing the slide and then reshare the slide again, so that we'll come to that slide. Yeah, it's your cursor is visible now. Yes. Yes. Yeah. Okay. Okay. Thanks.
So the anteversion is angle of anteversion is the angle between the long axis of the cervix and the long axis of the vagina, and it is around the 90 degree, while the angle of anteflexion is the angle between long axis of uterine body and the long axis of the cervix. So if uterus is not anteverted and anteflexed, then what happens? Then the position which results due to this, it is retroverted and retroflexed position of uterus, and in this the fundus and the body of the uterus bent backward on the vagina, so that they lie in the rectouterine pouch, and it compresses the sigmoid colon and the rectum. So this is the abnormal position of the uterus. So the fundus part of uterus is around 1.5 centimeter fundus part, and the body proper is around 3.5 centimeter. The constriction or junction between body and cervix is around 0.5 centimeters. The cervix is around 2.5 centimeter. So fundus, what is fundus? Fundus is dome-shaped part of the body above the area of the fallopian tube. So the part which is above the part of uterus, which is above the entry of the fallopian tube into the uterus, is known as the fundus. And fertilized ovum is implanted in the posterior wall of the fundus. Again, it is very important fact that the fertilized ovum is implanted in the posterior wall of the fundus. So, as I already told you, that fundus does not contain any uterine cavity. Next part is the corpus or body of the uterus, which forms the upper 2/3 of the uterus, and it is around the 5 centimeter in length. Cavity of cervix is between the internal os and the external os. Os is opening. So this narrow opening is the internal os, and this opening is the external os. So between both these openings, there is cervical canal. Cavity of the uterus is triangular in coronal section. Coronal section, if we cut the uterus in a coronal plane, then the cavity is triangular. But in sagittal section, it is slit-like opening because both the anterior and posterior walls are in contact. Upper 1/3 of cervix is called as the isthmus, which is the constricted part of the uterus between the body proper and the cervix. So this is the isthmus part. So isthmus is the upper 1/3 or nearly 0.5 centimeter of the cervix. It is a narrower part, transition zone, structurally similar to uterus. What happens during late pregnancy? This isthmus elongates and known as the lower uterine segment. Lower uterine segment. So when in pregnancy, when the uterus enlarges enormously, this isthmus helps in the enlargement of the uterus by forming the lower uterine segment. So this is the isthmus part. Cervix, it is the lower part of the uterus which communicate into the vagina, and it is also called as the neck of the uterus. Cervical orifice allows the passage of sperm into the uterus, and this forms the passage for menstrual flow also. This is less mobile than the body, 2.5 centimeter in length, and projects into the vagina and divides it into the supravaginal and vaginal part. So this is the cervix. This is the cervix, and it projects into the vagina. So this is the vagina. And due to this projection, it divides the vagina into two parts. One is the supravaginal part, and other one is the vaginal part. So projects into the vagina and divides it into the supravaginal and vaginal part. There are many longitudinal mucosal folds in the anterior and posterior wall of cervical canal, along with oblique folds, which forms the arbor vitae uteri. So arbor vitae is the arbor means like a tree, like a tree. So due to these mucosal folds, the appearance of this cervix is like a tree, arbor vitae uteri, which help in the locking the canal. So these mucosal folds prevents the entry of the sperm into the vagina. So this is the uterus, which is this fundus part. This is the body proper. And here it is the constriction of uterus. This is cervix. And this is the vagina. So this is the specimen, dissected specimen of uterus with vagina. And these are the mucosal folds, which gives the arbor vitae uterine pattern. So external os is the opening through which cervical canal communicate with the cavity of vagina. So this is the external os, this is the cervical canal, and this is the cavity of vagina. So in newborn and nulliparous woman, nulliparous means the female which doesn't give rise to any birth of child. Then in the newborn and nulliparous, this is the transverse slit-like, circular in newborn, and in the adults, this is transverse slit-like. So external shape of external os varies in the nulliparous and in the adult or multiparous female. So in the multiparous, because it is slit-like opening, so there are two lips, anterior lip and posterior lip. So this opening is bounded by the two lips. Anterior lip is shorter and more muscular, while the posterior lip is longer and thinner, less muscular. And this external os is most vulnerable to diseases because it is a site of changes of two types of epithelia. Because cervical epithelia is the columnar type of epithelia, while the vaginal epithelium is the stratified squamous type of epithelium. So there is transition of epithelium. That's why this is the most vulnerable region for the diseases. Uterus has two surfaces. One is the anterior surface or vesical surface. Why vesical? Because it is related to the urinary bladder. So this is the urinary bladder. And this is the anterior surface of uterus, which is related to urinary bladder. This surface is flat, directed downwards and forwards, and it is covered with the peritoneum up to the isthmus. So this peritoneum, which is covering the anterior surface, it only covers anterior surface up to the isthmus, till the isthmus, and then it reflects. Then it reflects upward, forming the uterovesical pouch. Uterovesical pouch. So this anterior surface of uterus is related with the urinary bladder. It forms the posterior wall of the vesico-uterine pouch. So this is the pouch which is formed due to reflection of peritoneum from the anterior surface of uterus. And also it is related to the vaginal portion of cervix. This is the vaginal portion of cervix and related to anterior fornix of the vagina. So this fornix is the anterior fornix of the vagina. Posterior surface, this is the posterior surface or intestinal surface because it is related to intestinal loops. So this surface, posterior surface, is convex, directed upward and backwards, and covered with peritoneum up to the posterior fornix of vagina. So this is the vagina, and here it is its posterior fornix. This posterior surface of uterus is also related to coils of ileum and sigmoid colon. And this forms the anterior wall of recto-uterine pouch. So there is formation of two pouches, one anteriorly, which is vesico-uterine pouch, and other one is posteriorly, which is known as the recto-uterine pouch. So anterior surface is forming the posterior wall of vesico-uterine pouch, while posterior surface is forming the anterior boundary or anterior wall of the recto-uterine pouch. There are two lateral borders of the uterus, right and left. These lateral borders are rounded and convex and provide attachment to the broad ligament. At the upper end of this lateral border, it is related to the uterine tube. This is uterine tube. Antero-inferior to the tube, there is round ligament of uterus, which is also attached to the lateral border of the uterus. Posterior-inferior to the tube, there is ligament of ovary. So lateral border is related to the ligament of ovary, to the uterine tube, and to the round ligament of uterus. Uterine artery ascend along the lateral border of the uterus between the two layers of the broad ligament. This is the uterine artery, which is running along the lateral border of uterus. Two lateral angles of cornu are there in the uterus, which projects outwards from the junction of the fundus and the body. This is fundus and this is body. So at the junction of fundus and the body, lateral angles are there. Each angle present the attachment of again three structures which are related with lateral border also. One is the uterine tube. It is the uppermost structure, proximal part of round ligament of uterus, below and in front of the tube, and ligament of ovary, below and behind the tube. So see the relation. This is the fundus part of the uterus. This is body of uterus. And there are structures. This is the uterine tube. This is the ligament of ovary. This is the ligament of ovary. And this is the round ligament of uterus, which all these three structures are related to the lateral angle of the uterus. It is the urinary bladder anterior to the uterus. Behind there is rectum. And between the urinary bladder and the uterus, there is vesico-uterine pouch. And between the uterus and the rectum, there is recto-uterine pouch. So the muscular, the histology, also it is related to histology, and also it is consisting of the gross anatomy of uterus, the muscular arrangement. So there are three layers. One is the perimetrium serosa, which is outer serous coat, perimetrium serosa. Next, there is the myometrium, which is the muscular layer, and it is around 12 to 16 millimeter. Consists of smooth muscle, and main branches of blood vessels and nerves of uterus are running through this layer only. Next, innermost there is the endometrium, which is the mucosa of the uterus. So this is the endometrium layer. So in the myometrium, the fibers are arranged longitudinally and also circular form. So longitudinal fibers are running in crisscross pattern, or interlaced, forming the figure 8 patterns. So these fibers are running like that, but they are forming figure of 8. This arrangement of longitudinal muscle fibers act as the living ligation, because blood vessels which are running through this muscle are blocked or obstructed by constriction of these muscle fibers. So arrangement of this type of muscle fibers act as living ligature, which help to stop bleeding. At the os, internal os and external os, the muscle fiber is arranged circularly, and they are concentrated in the form around the cervical os and keep the os closed. Endometrium, it is the inner layer of uterus. It is responsible to the cyclic variations of estrogen and progesterone during the female reproductive cycle every month. So there are three layers of endometrium. One is compact layer, second one is the basal layer, and third one is the functional spongious layer. Stratum compactum, stratum basale, and a stratum spongiosus. So this functional layer or spongious layer is shed during each menstrual cycle and after childbirth in the form of lochia. So after childbirth, the menstruation consists of this layer, and it is first menstruation is known as the lochia after childbirth. There are many ligaments which supports or hold the uterus in position. So there are 3 ligaments for body. One is the ligament of uterus, ligament of ovary, broad ligament. 3 ligaments of cervix are there: pubocervical ligament, uterosacral ligament, and transverse cervical ligament. So these are the ligaments, all ligaments which are related to body of uterus and the cervix. Now we can classify the ligaments according to true or false ligament also. So ligaments which are peritoneal force only, they are known as the false ligament because they are not providing much support to the uterus. They are not providing much support to the uterus. They are just force, peritoneal force. So one ligament is the anterior ligament, which is also known as the utrovesical fold. So this fold is the fold of pouch, the utrovesical pouch. Posterior fold or posterior ligament consists of rectovaginal fold, which is part of rectovaginal pouch. Third one is the broad ligament. So this whole is the broad ligament. So this point also you have to remember that broad ligament, as the name suggests, it is broad, covering covering the large area of the uterus, but it is not a true ligament. It is a false ligament of uterus. So what are the fibromuscular ligaments or true ligaments? These are the round ligament of uterus, transverse ligament or cervical, transverse cervical ligament or McInrod's ligament or cardinal ligament. So this is the transverse cervical ligament or McInrod's ligament. Uterosacral ligament is there. This ligament is the uterosacral ligament, extending from the uterus to the sacrum. And other one is the pubocervical ligament. Pubocervical ligament. So let's see all these ligaments one by one. So broad ligament is a double layered fold. This whole is the broad ligament. This whole is the broad ligament. Double layered fold of peritoneum extends from side of uterus to the side walls of the pelvis, and it is a false ligament, so it doesn't provide support to the uterus. Broad ligament. What are the parts of broad ligament? One is the mesosalpinx. So this is the mesosalpinx. This is the mesentery of the fallopian tube, which lies between the fallopian tube, mesovarium, and the ligament of ovary. Between the fallopian tube, mesovarium, and the ligament of ovary. So this is the mesosalpinx, part of broad ligament. Mesometrium is the mesentery of uterus, the largest portion of the broad ligament. This whole is the mesometrium. Below the uterine, below the ligament of ovary. Below the ligament of ovary. Suspensory ligament is this. Suspensory ligament of ovary or infundibulopelvic ligament. It is a peritoneal fold which transmit ovarian vessels, nerves, and lymphatics to the broad ligament. Extends from the tubal end to the pelvic wall. So tubal end of the ovary से लेकर ये pelvic wall तक extended है. Infundibulopelvic ligament. So these are the parts of broad ligament only. One is the mesosalpinx, second one is the mesometrium, and third one is the suspensory ligament of ovary or infundibulopelvic ligament. All these 3 parts. There are 2 layers of broad ligament. One is upper layer or posterior layer, because it lies posteriorly and superiorly. And this layer is related to the coils of small intestine connected to the ovary by mesovarium and pierced by the lateral end of the fallopian tube. Pierced by the lateral end of the fallopian tube. Lower layer or anterior layer has 4 borders. One is upper border. Its medial part covers fallopian tube and lateral part forms the suspensory ligament of the ovary. So broad ligament has, we already seen our slides that broad ligament has three parts. One is suspensory ligament and the mesosalpinx part. So upper border of anterior layer or lower layer, it is covered medially by the fallopian tube, laterally by the suspensory ligament of ovary. Lower border rests on the pelvic floor. Medial border attached to the side of uterus and lateral border attached to the side wall of the pelvis. So superior border of anterior layer, inferior border of anterior layer, medial border of anterior layer, and lateral border of anterior layer. What are the contents of the broad ligament? So there are two tubes. One is the fallopian tube and other one is the ureter. Two ligaments are there. So this is the fallopian tube and this is the ureter. So two tubes are there. Two ligaments are there. Ligament of ovary and round ligament of uterus. So ligament of ovary and the round ligament of uterus is there in this broad ligament. There are two arteries, uterine artery and ovarian artery. Uterine artery and ovarian arteries which anasmose in the broad ligament only. Two embryological remnants are there, apophoron and parophoron, which are the remnant of the mesonephric tubules only. Sympathetic nerve plexus are there, connective tissue is there, lymphatics and lymph nodes are there. So contents of broad ligament, we can remember like this only. Broad, B stands for bundle, neurovascular bundle, uterine artery and ovarian artery. R, round ligament. O, ovarian ligament. A, artifacts or vestigial structures, apophoron and parophoron. Ducts, oviducts and the ureter. Oviducts and the ureter. And connective tissue, lymphatics, lymph nodes are also there. Also sympathetic nerve plexus is also there. So sometimes short notes on broad ligament asked. So you have to describe all the two layers of the broad ligament, the contents of the broad ligament and attachment of broad ligament. We can also classify the ligaments according to supports of the uterus, primary support and secondary supports. So primary supports consist of the main support of the uterus, while the secondary supports are merely the peritoneal force, which not provide so much support to the uterus. So primary supports are the muscular support, which consists of pelvic diaphragm, perineal body, muscles of urogenital diaphragm. Fibromuscular support includes true ligaments, and visceral support, the viscera which are supporting the uterus. One is the uterine axis, urinary bladder, and the vagina. Secondary supports are actually the false ligament, which are the peritoneal force. So primary supports, the muscles which are forming the primary supports are the levator ani. So this muscle is the levator ani, which consists of two parts. One is the iliococcygeus, extending from iliac part of the hip bone and the coccygeus part of the sacrum. Other one is the pubococcygeus part, which is extending from the pubic bone and the coccyx. So iliococcygeus and pubococcygeus, which are part of the levator ani, it forms the primary support of the uterus. Second is the perineal body. This is the perineal body, which also supports the uterus because around 10 muscles are attached to this perineal body. 10 structures are attached to this perineal body. Third is the coccygeus muscle. All these structures prevent the sagging of the uterus during increased intra-abdominal pressure. Levator ani and the coccygeus muscle together forms the pelvic diaphragm. So pelvic diaphragm includes in the primary support of the uterus. So this perineal body is the mass of fibromuscular tissue in midline at the junction of the urogenital triangle and anal triangle. So this triangle, which is anteriorly situated, it is the urogenital triangle, while this triangle, which is posteriorly situated, it is the anal triangle. So perineal body is the fibromuscular mass of tissue. Here, superficial transperineal muscles are attached, bulbospongiasis muscle is attached, and the levator ani. External anal sphincter is also getting attached to this perineal body. So perineal body forms major primary support of the uterus. Next primary support is the urogenital diaphragm. So this is the urogenital diaphragm. Urogenital diaphragm consists of the deep transverse perineal muscles and the sphincter urethrae muscle. It has two fascia. One is the superior fascia and other one is the inferior fascia. This inferior fascia of the urogenital diaphragm is quite thicker and it is known as the perineal membrane. So this urogenital diaphragm is holding this uterus. This forms the primary support of the uterus. So this urogenital diaphragm again consists of the sphincter urethrae muscle and the deep transverse perineal muscle. Now the ligaments which forms the primary support. These includes the transverse cervical ligament or cardinal ligament or McInrod's ligament. Pubocervical ligament is extending from the pubic part to the cervix. Uterosacral ligament extending from the uterus to the sacrum, and the round ligament. These ligaments are the condensation of the pelvic fascia, and these are the true ligaments. These are the condensation of pelvic fascia, not the fold of peritoneum. So transverse cervical ligament, it is main ligament. It is fan-shaped, right and left, both the sides, and it is derived from the condensation of pelvic fascia or parametric tissue. It extends laterally from the cervico-vaginal junction to the fascia covering the levator ani. So this is the transverse cervical ligament of McInrod's or cardinal ligament. This ligament is related above with the crossing of the ureter and uterine artery. So this site is the crossing of ureter and the uterine artery. This transverse cervical ligament is attached here at the junction of cervix and the vagina, cervico-vaginal junction. So this is the transverse cervical ligament. Each ligament keeps the cervix in position and prevents the downward displacement of the uterus through the vagina. So it will prevent the uterine prolapse through the vagina. Hence, it is known as the cardinal ligament of the uterus. That's why it is known as the cardinal ligament of the uterus. And when in the case of uterine prolapse, this ligament is tightened during surgical repair. This ligament is tightened during surgical repair of the prolapse of the uterus. Next one is the pubocervical ligament, which extends from front of the cervix. From front of the cervix to the back of the pubis, and around the sides of the urethra, This pulls the cervix back and counteract the excessive traction of the uterosacral ligament. So pubocervical ligament and the uterosacral ligament both are maintaining the anti-burden and anti-flexion position along with the round ligament of uterus. Next is the uterosacral ligament. This is the uterosacral ligament which extends from back of the cervix and vagina to the second and third piece of the sacrum, and it passes along the side of the rectum. It pulls the cervix backwards, and again it helps in the maintenance of the anti-burden and anti-flexion. So uterosacral ligament, pubocervical ligament, and round ligament of uterus, all these three ligaments are maintaining the normal position of the uterus, which is anti-burden and anti-flexion. So see this in this diagram. Posteriorly, there is uterosacral ligament. In the middle, transverse cervical ligament is there. Anteriorly, there is pubocervical ligament. These are the suspensory ligament of ovary. This is ligament of ovary. Mesometrium is there. Mesoovarium is there. This is mesosalpinx. And this is the uterosacral ligament. So round ligament of uterus, which is the true ligament, it is fibromuscular band around 10 to 12 centimeter in length. So this is the round ligament of uterus. And it lies below and in front of the uterine tube. These are the uterine tube, and round ligament of uterus lies below and in front of the uterine tube. It passes forwards laterally through the broad ligament, because round ligament of uterus is the content of the broad ligament. So it passes through the broad ligament only. It enters the inguinal canal through the deep inguinal ring, then come out through the superficial inguinal ring, and at the exit of the superficial inguinal ring, it merges into the tissue surrounding superficial inguinal ring. So if you have an idea about content of inguinal canal, then you also know that this round ligament of uterus is content of inguinal canal also. Okay, content of inguinal canal also. So it passes through the deep inguinal ring, then traverses through the inguinal canal and come out through the superficial inguinal ring. And finally, it splits into a number of fibrous thread and attached to the subcutaneous tissue just outside the superficial inguinal ring. And this round ligament pulls the fundus forward and help to maintain the anti-burden and anti-flexion along with the uterosacral ligament. So uterus is supplied by the anosmosis of the ovarian artery and the uterine artery. So ovarian artery arises directly from the aorta, which passes through the suspensory ligament of ovary, then passes through the mesovarium and goes to the broad ligament and supplies the uterus. Uterine arteries are branches of the anterior division of internal iliac artery, and they ascend along the lateral border of uterus and forms the anosmosis with the ovarian artery and supplies the uterus. So uterine arteries are actually giving some branches for supplying the uterus. One is the arcuate artery or coronary artery. Arcuate and coronary artery of both sides anasmose on the anterior and posterior surfaces of the body of uterus. Radial arteries, which arises from these arcuate arteries, they pierce the myometrium. These radial arteries pierces the myometrium centripetally and anasmose with each other to form the stratum vasculaire. So these coiled arrangement of artery is the stratum vasculaire in the middle layer of muscular coat. Basal arteries and the spiral arteries. This is the basal artery and this is the spiral artery, which arises from this stratum vasculaire. So both these basal arteries and spiral arteries supplies the endometrium. So there are three types of arteries. One is the arcuate artery, which is arising from the uterine artery. Then further radial arteries arises from these arcuate artery, which radial arteries form the stratum vasculaire in the middle layer of muscular coat, and further from this basal artery and spiral arteries arises and they supply the endometrium. Venous drainage is into the internal iliac veins through the uterine and vaginal veins. So this is the vaginal vein and it is the uterine vein. Nerve supply of uterus is through the inferior hypogastric plexus and ovarian plexus. And this plexus is formed by the sympathetic nerve, which arises from T12 and L1, and they produce uterine contraction and vasoconstriction. Sympathetic supply. Parasympathetic nerves arises from the S2, S3, S4 segments, and they produce uterine relaxation and vasodilatation. Pain sensation from body pass along the sympathetic nerves and from the cervix along the parasympathetic nerves. So this fact is also important. Pain sensation from uterus carries through the sympathetic supply and from the cervix through the parasympathetic supply. So pain associated with uterine spasm is referred to the T12 and L2 sympathetic supply dermatomes. So referred pain, which arises from T12 and L2, goes to mid-back, pubic region, inguinal region, and anteromedial aspect of the thigh. While the pain associated with the cervical dilatation is referred to the sacral dermatomes and what are the regions which are related to this? Perineum, gluteal region, and posterior aspect of thigh. So this referred pain is referring to which region is also very important, whether it is uterine origin or whether it is cervical origin. Lymphatic drainage of uterus is very, very important because uterine cancer spread through these lymphatics and the lymph drained by the lymphatics draining the uterus drain into variety of lymph nodes. This the fundus part and upper fundus part of the uterus or the upper 1/3 of uterus, lymph from this region drain into the pre and para-aortic lymph nodes. So lymph from this upper 1/3 goes to the pre and para-aortic lymph nodes. While the middle 1/3, lymph from this region drains into the external iliac lymph node. So middle 1/3 goes to the external iliac lymph nodes. From lower 1/3 goes to the sacral lymph node and also to the internal iliac lymph nodes, external iliac lymph nodes, and obturator lymph nodes. The intramural part or the angle of the uterus or intramural part of the fallopian tube, lymph from here goes to the superficial inguinal lymph. So lymphatic drainage from the uterus is widespread. That's why uterine cancer spread drastically to all these regions. all these regions. So again, the upper 1/3 drains into the pre and para-aortic lymph nodes. From middle 1/3, lymph goes to the external iliac lymph nodes. From lower 1/3, including the cervix, goes to the internal iliac lymph nodes, external iliac lymph nodes, sacral nodes, and obturator nodes. Angle of uterus, lymph from this region goes to the superficial inguinal lymph nodes. So, uterus changes in shape and size as age progresses. In newborn, the body is around 1/3 of the total length, while the cervix is around 2/3 of the total length. In adult nulliparous women, it is half and half, 1:1 ratio of the body and the cervix, while in adult parous women, the body is 2/3 and the cervix is 1/3 only. In postmenopausal, again, it comes to the 1:1 ratio. Body is half and cervix is half. So, due to enlargement in from newborn to the adult, due to this enlargement, the size and shape of cervix changes. And also in pregnancy, there is enormous enlargement of the uterus. One term is endometriosis, which is a benign disorder due to proliferation of endometrial tissue outside the endometrial cavity of uterus. So this uterine tissue, the endometrial layer, the tissue of endometrium, proliferate outside the uterus, and this give rise to symptoms of abnormal bleeding or intermittent bleeding besides the menstrual bleeding. So this is the benign disorder, endometriosis. If not treated, then it may lead to the infertility and also cancer. Leiomyoma or fibroid, most common benign tumor, and it affects the uterine musculature. So fibroids may arise into the wall of the uterus, which is known as the intramural fibroid, or it may arise in the serosa, subserosal fibroid, or in the mucosa layer, submucosal fibroid. Again, these fibroids are responsible for abnormal uterine bleeding. Carcinoma of cervix, it is most common cancer in elderly females and peak between 45 to 55 years. So every 7 minutes, one Indian woman dies of cervical cancer. So this is a disease burden, very common. Malignant growth, in this cervical cancer, malignant growth common in cervix, then the body of uterus, and it spreads rapidly due to abundant lymphatics. And the main cause for this cervical cancer is the human papilloma virus, HPV virus, human papilloma virus. So against this virus, vaccine is recommended for routine vaccination at the age of 11 or 12 years. Vaccination can be started at the age of 9, and ACIP Advisory Committee on Immunization Practices also recommends vaccination for everyone through the age 26 years, if not adequately vaccinated when younger. So the recommended age is the 11 or 12 years of age for this HPV vaccine or cervical vaccine. So this is a picture for the uterine prolapse. There are many degrees of uterine prolapse. Actually, you will study in the gynecological department about this. In this primary degree, there is descent of cervix, in the vagina. In secondary degree, descent of cervix to the introitus or internal os. In third degree, descent of cervix outside the introitus. And procedentia is the complete prolapse of the uterus, and all of the uterus lies outside the external os. So there are various degrees according to the protruded part of the uterus. So in this prolapse is only corrected by the surgical treatment only. And you have to ligate all the primary support of the uterus, especially the transverse cervical ligament of McEnroe's or cardinal ligament. These are the Nabothian cysts on the cervix, which are the mucous retention cysts around the cervix, and they are treated medically. These are the small growths from the cervix, which are known as the cervical polyps. And they are curated actually. Surgical treatment, small procedure is done, curettage is done to treat these polyps. Removal of uterus is known as a hysterectomy, and it is total hysterectomy if we remove uterus along with the cervix, and it is radical hysterectomy if we remove ovaries, tubes, lymph nodes, surrounding lymph nodes, and upper vagina. And this hysterectomy is done as a family planning method, and also for cure the malignancy of the uterus. So hysterectomy is the removal of uterus along with cervix or ovaries or surrounding lymph nodes and tubes and vagina. Intrauterine device or copper T, they are the devices for family planning, and they are impregnated with the hormones, and they are effective, 99% effective at preventing pregnancy, and they block sperm from reaching the egg. And they also there is one disadvantage. There is no prevention or protection from the STD, sexually transmitted disease, by intrauterine device. Otherwise, they are very effective in preventing pregnancy. A cesarean section for delivering the baby. We gave the incision in the lower abdominal wall. This is the incision, which is also known as the penisteal incision, which is a transverse incision in the lower abdominal wall. And this is known as the penisteal incision, which is given during cesarean section or C-section. Next is the vagina. Vagina is this part below the cervix and cavity of vagina communicating with the cervical canal through the external os opening. It is a fibromuscular tube which is present between the cervix and the vestibule. Vestibule is what? It is a cleft between the two labia minora folds. And this vagina is directed upwards and backwards, forming a right angle with the uterus. So commonly, vagina is known as the birth canal and capable of stretching to allow the birth. It is female organ of copulation, and it extends from the vestibule to the vaginal part of cervix. So this is the vagina, and this is the vaginal part of cervix. It is around 4 to 5 inches long. Diameter at the upper end is around 5 centimeter, and diameter at the lower end is around 2.5 centimeters. There is a fold, which is a mucosal fold, which closes the external vaginal opening here. And this mucous fold, which is covering this opening, is known as the hymen. During coitus, the hymen ruptures, and the ruptured portion or tags of mucous membrane called the caruncles. So this is the hymen of the multiparous lumen, and this is these are the caruncles, which are the tags of mucosal folds, which are formed due to rupture of this hymen. So hymen is examined for medical-legal purpose to confirm the virginity. There are several types of hymen: annular hymen, cribriform hymen, septate hymen, and imperforate hymen. So this imperforate hymen means there is no opening, and this is the cause for blockage of menstrual flow. So what are the relations of the vagina? There are three walls of the vagina. One is the anterior wall. Posteriorly, there is posterior wall. And at both the sides, right and left, there are two lateral walls. So anterior wall is around 7 centimeters in length, and it is not covered by the peritoneum. Not covered by the peritoneum, because the peritoneum, which covers the anterior surface of the uterus, it reflected from the isthmus to form the vesico-uterine pouch. So upper 1/3 of this anterior wall is pierced by the cervix. Middle 1/3 of this anterior wall is related to the base of the urinary bladder. Base of the urinary bladder. And lower 1/3 is related to the urethra. So this anterior wall from upwards to downwards related to the cervix, base of urinary bladder, and the urethra. And it is not covered by the urinary, not covered by the peritoneum. Posterior wall is a little bit larger than the anterior wall. It is around 9 centimeters, while the anterior wall is around 7 centimeters. So this posterior wall, the upper 1/4 is covered by peritoneum. So this peritoneum, which is covering the posterior surface of uterus, covering this posterior fornix, and then reflected above to form the recto-vaginal or recto-uterine pouch or pouch of Douglas. So the upper 1/4 is related to the peritoneum, which contains coils of small intestine ileum. Middle 2/4 is related to the rectum, and lower 1/4 is related to the perineal body and anal canal. So upper 1/4 is related to the peritoneum, middle 2/4 is related to the rectum, and lower 1/4 is related to the perineal body and the anal canal. Lateral wall is related from above downwards. In the upper part, there is uterine artery and ureter. So superiorly, it is related to the uterine artery and ureter. Middle part is related to the levator ani muscle. So here it is. This is levator ani muscle. Okay. So this levator ani, fibers from this levator ani forms the sphincter vaginae. And lower part of vagina is related to the greater vestibular gland. Greater vestibular gland, which is the content of the perineum. There are 4 fornices of the vagina. So what are the fornices? These are the pouches. So there are 4 pouches formed by the upper part of the vagina around the vaginal part of cervix. So due to protrusion of this cervix into the vagina, these 4 fornices are formed. One is the anterior fornix, which is directly related to the base of urinary bladder. Posterior fornix, which is covered by the peritoneum of the rectovaginal pouch. And this fornix is the deepest fornix. And 2 lateral fornixes, which are related to the uterine artery and the ureter. So these are the pouches. So 2 arteries, in fact, many surrounding arteries are supplying the vagina. One is the uterine artery, which is the branch of the anterior division of internal iliac artery. This is the internal iliac artery. This is the uterine artery. Other one is the vaginal artery, which is again the branch from the anterior division of internal iliac artery, vaginal artery. Middle rectal artery, which is again the branch of the internal iliac, and the internal pudendal artery, which is again the branch of internal iliac artery. So all these four arteries are the branches of internal iliac only. These arteries anastomose in front and behind the vagina to form the anterior and posterior ischius arteries. So anastomoses is formed. This anastomoses is formed all these four arteries. Vaginal veins correspond with the vaginal artery, and they ultimately drain into the internal iliac veins. Lymphatics, in the point of lymphatic drainage of the uterus concerned with the vagina, we divide the vagina in upper 1/3, middle 1/3, and lower 1/3. Upper 1/3 of vagina, lymph from this part goes to the external iliac lymph nodes. Middle, from middle, lymph goes to the internal iliac lymph nodes, and from lower 1/3 goes to the superficial inguinal lymph nodes. So the vaginal part, upper 1/3 goes to the external iliac lymph nodes. Middle 1/3 goes to the internal iliac lymph nodes, and lower 1/3 goes to the superficial inguinal lymph nodes. Upper 2/3 of the vagina is pain insensitive because it is supplied by the autonomic fibers. Lower, and also by the sympathetic fibers coming from the L1 and L2 spinal cords, and parasympathetic fibers from S2, S3. So upper 2/3 is pain insensitive. Lower 1/3 is pain sensitive, and it is supplied by the branches of pudendal nerve. So lower 1/3 of vagina, including region of vaginal orifice, is extremely sensitive to touch, and it is supplied by the pudendal nerve via inferior rectal branches and posterior labial branches of perineal nerve. So pudendal nerve, the inferior rectal nerve is the branch of pudendal nerve. So this lower 1/3 of vagina is supplied by the inferior rectal branch of pudendal nerve, and also by posterior labial branches of perineal nerve, and it is very pain sensitive and sensitive to touch. So especially in during pregnancy, in first trimester of pregnancy, we do per vaginal examination or PV examination for assessing the progress of labor, for assessing the presenting part of the fetus, and for assessing the cervical dilatation. This is the endoscope which we use to examine internally the vagina. For internal examination of vagina, this is known as the coldoscope. This is known as the coldoscope, and this is a endoscope. Vaginitis is the infection of vagina, and as you know that vagina is self-sterilizing in adult due to its acidic medium. The pH of vagina is around 4.5. So in this pH, organisms are unable to survive. This acidic medium is maintained by the dorsal bacilli, which produce the lactic acid from the glycogen, which is present in the vaginal epithelial cells. And activity of this dorsal bacilli is dependent upon the activity of estrogen. But in children and old women, which are around the age of 50 years after menopause, vaginitis is very common because this hormone, estrogen hormone activity is very much suppressed, and the dorsal bacilli is unable to produce lactic acid to maintain vaginal pH. Trichomoniasis is the protozoa which causes vaginal infection, and it is the one of the organism which causes the STD, sexually transmitted disease. So there is very much chances of prolapse of anterior vaginal wall also, and this prolapse of anterior vaginal wall may drag the urinary bladder. Then it is known as the cystocele if it is along with the urinary bladder, or it may drag the urethra, which is known as the erythrocele. So cystocele is the prolapse of urinary vaginal wall along with the urinary bladder, and erythrocele is prolapse of anterior vaginal wall along with the urethra. The prolapse of the posterior vaginal wall drags the rectum, and it is known as the rectocele. What is cultocentesis? It is a clinical procedure in which a needle is passed through the posterior fornix of the vagina. Then the needle goes into the pouch of Douglas or rectouterine pouch, and the pus or blood which is present in the pouch, we are capable to drain. So we pass our needle through the posterior fornix into the pouch of Douglas to drain the pus in the pelvic inflammatory disease or PID or blood following rupture of ectopic tubal pregnancy. And nowadays, this cultocentesis is used to obtain a fluid sample for collecting oocytes for IVF or in vitro fertilization. So cultocentesis is the passing needle for collection of sample or for collecting the pus or blood through the posterior fornix of the vagina. So I want to revise the most important aspect of this lecture. So please 5 minutes, bear me for 5 minutes only. The supports of uterus are very important. That's why I want to repeat again. So there are primary support and there are secondary supports. Secondary supports are the peritoneal force, which are the anterior fold, anterior ligament or uterovesical ligament or fold, posterior ligament or rectovaginal fold, and the broad ligament. So these ligaments are the false ligament, and they are the secondary support of the uterus. But the true primary support consist of true ligaments, which are the fibromuscular support, visceral support, and the muscular support. In muscular support, we have levator ani muscle and the coccygeus muscle, which all together form the pelvic diaphragm. And the perineal body, urogenital diaphragm, this is the perineal body. Urogenital diaphragm is this. True ligaments which form the primary support are the transverse cervical ligament, pubocervical ligament, uterosacral ligament, and the round ligament. So true ligaments are the condensation of pelvic fascia. So this is the pubocervical ligament, uterosacral ligament. Round ligament of uterus is also the true ligament, gives primary support to the uterus, and it passes through the inguinal canal. Lymphatic drainage of uterus. We divide the uterus in 1/3 parts according the lymphatic drainage. So the upper 1/3, including fundus, lymph from this side goes to the pre and para aortic lymph nodes. From middle 1/3, lymph goes to the external iliac lymph nodes. And from lower 1/3, lymph goes to the internal iliac, external iliac, sacral lymph nodes, obturator lymph node. From the angle of uterus, lymph goes to the superficial inguinal lymph nodes. So what are the contents of broad ligaments? There are two tubes, fallopian tube and ureter, two ligaments, ligament of ovary and round ligament of uterus, two arteries, uterine artery and ovarian artery, two embryological remnants, apophoron and parophoron, sympathetic nerve plexus, connective tissue, lymphatics, and lymph nodes. These are the contents of the broad ligament. And broad ligament is a false ligament. It is not a true ligament. Uterine tube has 4 parts. First part is the intramural or interstitial part within the wall of uterus itself. Second is the isthmus. Third is the ampulla, which is the site of fertilization. And fourth one is the infundibular part. And length of this whole tube is around 10 centimeters. 10 centimeters. Arterial supply of fallopian tube. Medial 2/3 is supplied by the uterine artery and lateral 1/3 by ovarian artery. Hysterosalpingography is the visualization of the uterus and fallopian tube by injecting dye through the internal os. And most common indication for hysterosalpingography is the infertility. Spillage of dye denotes the patency of the uterine tube. Ovaries are located on the posterior aspect of the posterior layer of the broad ligament, and it is situated in the ovarian fossa. And the boundaries of ovarian fossa are anteriorly obliterate umbilical artery and the external iliac artery, posteriorly by the ureter and internal iliac artery, inferiorly by the uterine tube, and in the floor, there are obturator nerve and obturator vessels. So ovaries has 2 poles, tubal pole and uterine pole, 2 borders, anterior border or mesovarian border, posterior or free border, 2 surfaces, lateral and medial surfaces. Ovary is surrounded all around by the peritoneum except at its anterior border, where the 2 layers of peritoneum are reflected as mesovarium. So ligaments which are related to ovaries are suspensory ligament or infundibulopelvic ligament, ligament of ovary, and the mesovarium. Ovarian artery supplies the ovaries and veins. First, pampiniform plexus is formed. Then on the right, right ovarian vein is formed through this pampiniform plexus, which drains directly into the inferior vena cava. On the left side, left ovarian vein first drain into the left renal vein, and then this left renal vein drains into the inferior vena cava. Removal of ovary is known as the oophorectomy, and when we remove ovary with fallopian tube, then it is known as the salpingo-oophorectomy. Uterus measures around 7.5 centimeter in length, 5 centimeter in width, and 2.5 centimeter in thickness. It is around 30 to 40 grams only, 30 to 40 grams. Position of uterus is anteverted and anti-flex position. And the angle between the long axis of cervix and the long axis of vagina is angle of anteversion, and it is around 90 degree. Angle between the long axis of body of uterus and the cervix, long axis of cervix, is known as the angle of anteflexion, and it is around 170 degrees. So this is the angle of anteversion and this is angle of anteflexion. Isthmus is the part which is the transitional zone between body proper of uterus and the cervix, and during late pregnancy it elongates to form lower uterine segment. Lower uterine segment. In the cervix, in the anterior and posterior wall of cervical canal, mucosal folds are found. Longitudinal mucosal folds are found, which along with oblique folds form arbor vitae uteri, which help in the locking of the canal. Locking of the canal. External os in the newborn and in the nulliparous women, it is like a circular shape, but in the multiparous, it is sagittal or transverse slit-like. And because there is transition of two types of epithelia here, this external os is vulnerable to the diseases, very common. Uterus has two surfaces, anterior and vesical surface. Anterior surface is related with the uterovesical pouch, and posterior surface is related to the recto-uterine pouch or pouch of Douglas. This is the pouch of Douglas. Two lateral borders are there, and the uterine artery is crossed by the ureter. This site is again very important during surgery of uterus, because sometimes what happens, by mistake, this instead of ligation of uterine artery, we ligate ureter. So you have to very careful while ligation of uterine artery during surgery of uterus. So ureter is below the uterine artery. Ureter is below the uterine artery. Due to arrangement of muscles in the myometrium act as the living ligature to stop bleeding. So these are the ligaments. Broad ligament has three parts: mesosalpinx, mesometrium, and suspensory ligament of ovary. It has two layers. Okay. So that's all. I think it is completed. Yeah. So thank you. Thank you all. Yeah, thank you.